A 38-year-old woman comes to the emergency department due to a 3-day history of left arm weakness. She also reports urinary urgency and incontinence, but has no fever or dysuria. The patient was diagnosed with multiple sclerosis 10 years ago after an episode of right eye vision loss.
Look at this.
She was taking disease-modifying therapy, but stopped 2 years ago after being symptom-free for several years. Temperature is 37 C, 98.6 F. Blood pressure is 130/80 mmHg, and pulse is 88/min. She is oriented to person, place, and time. Visual acuity is 20/20 in both eyes. Fundus examination shows no abnormalities. Left arm and hand strength is decreased. Deep tendon reflexes at the knees and ankles are brisk bilaterally. Neuroimaging reveals new areas of demyelination compared to previous MRIs. Urinalysis is normal. Which of the following is the most appropriate next step in management of this patient?
Fucking... What's the diagnosis? A disease-modifying therapy. Symptom-free for years? This has got to be... Oh, okay. She also reports urinary... I don't know. It sounds like... Oh, yeah. I was going to say she probably has MS. But, yeah. Shoot.
C.
You think it's C?
I don't
Why?
know.
Okay. I think it's like either B or A. But like... Shit. Like...
A then.
Could be cortico, but I don't know. Like that's just like every time you have some sort of autoimmune issue, stop your body from attacking itself.
What is it?
Steroids.
Well, oh, that's steroids?
Yeah.
Oh. Cool.
This patient with multiple sclerosis MS has new, significant neurologic deficits that have lasted more than 24 hours without a precipitating factor. These deficits correspond to a new inflammatory plaque seen on MRI, consistent with an MS exacerbation, relapse. Patients with disabling symptoms due to these new lesions are treated with high-dose glucocorticoids, intravenous methylprednisolone, to reduce inflammation. Glucocorticoids also seem to decrease the ability of inflammatory cells to cross the blood-brain barrier, further decreasing inflammatory-mediated myelin destruction. ACDH is sometimes used to promote the release of endogenous steroids. Plasmapheresis should be considered in patients with MS flare who are refractory to corticosteroid therapy. Choice D. Treatment of acute exacerbation speeds time to improvement of neurologic symptoms, but does not change the ultimate disease course. Choice B. Interferon beta is one of many disease-modifying agents used for chronic maintenance.
So is it likely that this happened because she stopped taking her medication?
Yep. I mean, well, even on medication, people with MS can have acute exacerbations. It's a very chronic, debilitating disease, as they would say.
Yay.
A 21-year-old military recruit comes to the medical clinic due to right forefoot pain. She is in her second month of basic training and has had worsening pain for the past 3 weeks. The patient has no history of acute trauma. The pain initially occurred only with activity but is now present at rest. Medical history is unremarkable, and she takes no medications. Vital signs are normal. Examination shows swelling in the foot and point tenderness over the second metatarsal. Plain x-rays of the foot show a faint lucency over the shaft of the second metatarsal. In addition to appropriate analgesia, which of the following is the most appropriate next step in management?
Sounds like a podagra, in which case I guess she has gout or pseudo gout or some bullshit like that. Or it's none of the above. A faint lucency. I don't even know what that really means. Nah, that's too much. I mean, that would make sense, right?
But I think not C or D, right?
I don't know why we would need to do that. I don't know why we would need to do that. I don't think she has like multiple myeloma, but she might. It's just a stress fracture.
Interesting. Bro, you know why I'll never have like a full-time like fast food or like retail job again? My fucking
This is recording.
feet. Oh. I didn't
Just
know.
FYI.
Anyway, no, because like when I worked at McDonald's, bro, my feet always were like hurt so bad. They hurt so bad. Every day after work, my head too.
My feet would
But
get
that
hot.
was from my hair being in a ponytail all day.
Oh wow.
Or a bun.
The second metatarsal, which is subjected to significant
Pussy.
extremes of loading during gait, is most commonly involved. Typical findings include subacute, activity-related pain, which may progress to rest pain, and point tenderness over the fracture. Diagnosis is primarily based on clinical findings. X-ray is frequently normal within the first 2 weeks if positive findings are either a hairline lucency or a local periosteal thickening. MRI, CT scan, and scintigraphic bone scans are more sensitive, especially for early fracture, but are not usually needed. Choices A and B unless there is high risk for malunion. Egg, fifth metatarsal. Fractures of the second, third, and fourth metatarsals are managed conservatively as the surrounding metatarsals act as splints and non-union is uncommon. Initial interventions include cessation of repetitive activity, egg, marching, running, and simple analgesics, egg, acetaminophen. Some experts advise against nonsteroidal anti-inflammatory drugs due to a possible delay in healing times. Patients who continue to have pain despite activity restrictions may additionally be managed with a wide, hard-sole podiatric shoe.
Let's give your sister a shoe.
Anyway, so when I was working at McDonald's is like when I got the majority of the spider veins on my foot.
Oh.
Or varicose veins or whatever.
Your telangiectasia?
Yeah, those things. Yeah.
Oh, wow. You have another... Your whole family just has every congenital disorder.
I mean, we're white.
In the
so
book.
Like, maybe.
A 26-year-old man is brought to the emergency department by a colleague due to anxiety. The patient experienced a 15-minute episode of chest pain, shortness of breath, and dizziness prior to giving a presentation at a regional meeting. He says, "My girlfriend used to help me prepare for all of my meetings. She always knew what to say and how to handle everything. I can't manage at work without her." His girlfriend broke up with him 2 weeks ago after a 9-year relationship. The patient's colleague, who has known him since high school, says he did everything to make her happy. He let her choose his car and agreed to get a cat even though he's allergic. The patient reports feeling lost and on edge since that time and has avoided leaving his apartment. He is anxious about driving on his own and is planning to move in with his parents when his lease expires. The patient denies prior episodes of chest pain, shortness of breath, or dizziness and has no significant medical history. Family history is significant for generalized anxiety disorder in his mother. Vital signs are within normal limits, and physical examination is non-contributory. ECG is normal. Which of the following is the most likely diagnosis in this patient?
Yeah.
So I think, well, here's the thing. It's obvious he was super dependent on his girlfriend, right?
Yeah.
But what if adjustment disorder? He's adjusting. He doesn't actually so it could be, and his panic attack that he happened, he definitely had a panic attack. But it was right before a presentation. So that, I don't know. He doesn't seem to be panicky now that he's broken it up. I think that because the majority of this excerpt is focused around him and his girlfriend, I'm going to go with the dependent, which is correct.
I think that's what my
Swish.
aunt has. My aunt, who just moved in with
Oh,
her
probably,
parents.
you white people. All right.
A 1-year-old girl is brought to the emergency department because she is not moving her right arm. Her father says that the girl acted normally when she awoke this morning. He was swinging her by the forearms when she suddenly started crying and refused to use her right arm. He has swung her by the arms previously, and it usually makes her laugh. The girl lives with her father and her mother, who is currently out of town. Physical examination shows a well-nourished child who holds her right arm in pronation against the chest. She avoids any movement of her right arm. There is no bony tenderness to palpation. No bruises or other abnormalities are seen. Which of the following is the most appropriate next step in management of this patient?
Okay, so this is a pretty classic case of I forget if it's called milkmaid's elbow or radial head subluxation, or if it's ulnar. No, it's got to be debatable. I think it's radial head subluxation. In which case, do we need an X-ray? I want to say yeah. Okay, so it says right arm. So yeah, so that sometimes they try to throw you off by saying left arm, and it's see, we tried to give you the hint. You said left arm. The left arm's fine, you dumb bop. Learn to read. And I'm fuck. I wish I knew how to read. So yeah, I don't know. I would order an X-ray. Unlucky. But I did get the diagnosis, nursemaid's elbow, like on point.
What is hyperpronate?
Hyperpronate is like, okay, so this is supinate and this is protonate. And like how some girl in my class taught me, which was genius, was supination and protonation. Supination is a bowl of soup. And then protonation is just the other way. But like the bowl of soup thing, oh man, just clicked. That's supination. This is protonation.
Wait, which way is the way where the bones are crossed?
Okay, that doesn't. That was. Okay, so I don't know what the treatment is. Okay, but hyperprotonation of the forearm, so, or supination of the forearm and flexion of the elbow. Interesting. It just seems kind of like, okay, so arm is held extended and protonated. So how would just like that, bro, I would love to see this in person. Let's see. Oh, they have little images over here.
Radial head subluxation, nursemaid's elbow, is a common injury in preschool children. The injury characteristically occurs from innocent swinging of a young child by the arms, or pulling a child's arm while in a hurry. The child is usually not in distress at presentation, but may cry at any attempt to move the elbow or forearm. The preferred treatment of this condition is closed reduction by applying pressure on the radial head and hyperpronating the forearm. Forearm supination with elbow flexion is also commonly performed, but may be less successful and more painful. No post-reduction films are needed when the patient resumes full use of the extremity. A pop may also be heard on successful reduction.
Ooh, we're gonna pop this bitch. Oh, they got an image. I mean a video. It's a GIF. Oh shit. Oh shit. Oh shit. Oh shit. What? Dude, that's trash in my opinion. That doesn't even look like it's helping at all. Oh yeah, that looks good. Oh yeah. Oh yeah, that's how I want to do it. Just fucking get him good. Get him good. Yeah, but no, like literally like what will happen is like I tried to grab onto my kid who's running in the other direction and I guess I yanked too hard, you know? And like normally you're like, oh, so you yanked too hard. I need to make a call. No, this is very common in children, and it's not the parents' fault. This is like most children are like really indestructible in general, except for very rare times, like when you shake them as a baby. And there are ways that you can determine that they shaked the baby because we have these findings that do not appear other than shaking the baby. For example, how would you like think, or how do you think like doctors know to like?
If they grow up and get Cash App.
Okay, that's correct, but like immediately.
Oh, when they're still a baby?
Yes.
How?
Huh?
How?
So like when you shake the baby too hard, little micro hemorrhages happen at the back of their eyes that does not occur in like accidental trauma, right? It just doesn't occur. So what we do is we look at the back of their eyes, we see if there are these hemorrhages. There's a specific term for these hemorrhages, but if I saw it, I'd be like, they're abusing that kid. Yeah, so I didn't know this. This is interesting.
One, two, three. 1, 2,
No.
3. A 77-year-old woman is admitted to the intensive care unit due to pneumonia. She has a history of idiopathic pulmonary fibrosis that has progressively worsened over the past 2 years with increasing weight loss, weakness, fatigue, and dependence on supplemental oxygen. Her life expectancy is less than 6 months. The patient is alert and oriented. The attending physician examines her and explains that appropriate antibiotics will be administered to treat pneumonia. After reviewing the patient's medical record, the physician believes that a do not resuscitate order may be appropriate and prepares to initiate discussion with her regarding code status. Which of the following statements is most appropriate?
All right, I got like a few more questions.
1. 2.
God damn.
A 72-year-old woman diagnosed with osteoporosis and recovering from a recent vertebral fracture caused by a fall is concerned about future vertebral fractures. She reads a magazine article on how drug Z reduces the risk of new fractures in patients with osteoporosis by 60%. The report states that patients in the study were randomly assigned to either the new drug or placebo. The incidence of new fractures in the drug Z group was 10%, whereas in the placebo group it was 25%. Which of the following was most likely presented as the 60% reduction in fractures?
That would only be absolute risk, relative risk, not absolute. Fuck. I knew it was like one of these three. Relative risk. But the absolute risk reduction is the control rate minus the treatment. Absolute risk or the absolute versus the relative. The control versus the treatment versus the relative would be the absolute divided by the control rate. Bruh, this is like too much. I don't know.
Yo, so like, are you posting this video or is this just for you?
I post it to YouTube for myself.
Oh, but publicly or private?
Private.
Oh,
Like, well,
okay.
I post it under like,
Anyone with a link thing?
no,
Oh.
to my NSU dank memes account. Yeah.
A 46-year-old man comes to the
Just in case
emergency
U-World
department due
wants
to
to come
intermittent
after me.
severe right flank pain over the past few days. He has had decreased urination
For
over the
copyright.
last week, but has also noted occasional episodes of high urine output, along with a feeling of generalized weakness. The patient has a history of chronic back pain for which he takes oxycodone daily, and he underwent a left total nephrectomy following a motor vehicle accident 25 years ago. He was recently started on low-dose lisinopril for a new diagnosis of hypertension. There is no family history of renal disease. On physical examination, blood pressure is 145/86 mmHg, and heart rate is 86/min. Laboratory results are as follows.
Okay, so decreased urination, like hot, general. What? This literally sounds like this related. Yeah, he's having some sort of renal disease happening. No, he didn't inherit this. He did it to himself. That sounds about right. That would be a higher blood pressure, I believe. Yeah, so adrenal tumor. Did they say there was a mass? Nope. Glomerulonephritis. There are red blood cells, but I don't see casts.
What does nephritis mean?
Just means like inflammation of the nephrons, like the little cells in the kidneys.
Oh.
Yeah. Could be like an infection, or could be autoimmune related. Could be a bunch of other stuff, but irritation,
Cool.
inflammation, itis, hepatitis. Yeah. Damn, bro. I don't know why it would be but I at least like was like, okay. What is your reasoning?
This patient with a history of total nephrectomy now most likely has unilateral obstructive uropathy due to renal calculi. Symptoms that support this diagnosis include flank pain, renal capsular distension, and poor urine output, mechanical obstruction to urine outflow. Intermittent episodes of high-volume urination can occur when the obstruction is overcome by a large volume of retained urine. Post-obstructive diuresis. Excessive diuresis may lead to potassium wasting
I ain't
and
never heard
dehydration
about
both of,
that.
which can cause weakness. Post-obstructive diuresis may
Potassium
be seen in
wasting.
patients with bilateral functional kidneys, as the affected kidney will produce a large volume of urine when the obstruction is relieved. However, patients with a single kidney are more likely to develop acute renal failure than are those with both kidneys intact.
Duh. That's why they say don't just give a kidney. Don't do that.
Obstructive uropathy presents with flank pain, low volume voids with or without occasional high volume voids, and
This
if
is a
bilateral,
good
renal
test.
dysfunction.
That was a good question.
1, 2,
No.
1,
No.
2. An 81-year-old woman with a history of chronic atrial fibrillation and mitral valve replacement maintained on warfarin is admitted to the intensive care unit due to pneumonia. The patient develops asymptomatic runs of ventricular tachycardia. A cross-covering provider, who is normally based in a different unit, pages the attending physician. The physician is performing a sterile procedure and another unit and asks a resident to communicate a verbal phone order for 20 mg of oral potassium supplementation. The resident states the order as, give 20 of K now. The cross-covering provider enters the verbal order as, give 20 milligrams of vitamin K intravenously now. The patient receives the medication. The following day, her INR is subtherapeutic. Which of the following could have prevented this error?
Reading it back, bruh. No. Maybe. The fuck is closed loop technique? I don't know what sign out is.
Like, I think that means, like, they'd, like, email back or, like, message back saying, like, okay, so you want 20 milligrams intravenously? And then, you know, they'd be like, correct. Or, like, they'd be like, no. You know. But I don't know if that's what that actually is.
Sure. Yeah, I've never heard of closed loop technique. The fuck is that? Ah, see? Read back. I did not know that. I knew read back was what they wanted.
Yeah.
I said it. Read back.
Yeah.
You have to say it back exactly how you think you're about to deliver it, you know?
So it's what I thought sign out communication was.
Yeah, exactly. And that's what I thought. So it's like,
wait, so what is sign out communication?
Let's see. What was it? D?
Checklists improve safety by standardizing high-risk processes. Preventing incomplete sign-out.
It's literally a checklist, I think.
Okay.
No, that's checklist. So this is...
Administering tissue plasminogen activator to patients with suspected stroke.
What?
Complete sign-out and improve safety by standardizing high-risk processes. Preventing incomplete.
I mean, yeah, this wasn't even in sign out though, so I can't tell you. But basically, like, when you leave, you got to make sure that everything is like tip top. I think that's what I was trying to say.
It's like theater.
Yes, but not.